Welcome, everyone, to the Lyfebulb seminar focused on financial planning and Medicare coverage in end-stage renal disease, which also, of course, includes transplantation. My name is Karin Hehenberger. I am the president of Lyfebulb, but I am also a kidney-pancreas transplant recipient. And I'm really privileged to have with me here today two excellent, knowledgeable colleagues. Kevin Schnurr, who is our community manager and also a fellow kidney transplant recipient. And of course, also back again with us, and we're really, really privileged to have Craig Pressley here as the social work leader at the Beth Israel Deaconess Center. And I'm going to give the floor to Craig, really to take us through some cases. As you remember, we had a first session focus on this very topic where Craig and Kevin took us through the basics. And now we're going to illustrate these kind of facts and make it real through some cases. And I think that will make this more clear to everyone. We really tried to emphasize some these cases being realistic, and I hope that we can kind of elevate our N of ones. We've all experienced this to a certain extent. Everyone has been through the transplant, but now we're going to make it practical. So again, Craig, take it away.
Thank you very, very much. I am going to share my screen, and it's absolutely a privilege to be able to be back with you and speak with you about this really important topic. Let me see if I can remember how to share my screen here. Here we go. And okay, tell me if you can see my screen okay.
Yes.
Did I do everything right? Yeah, I'm not a technological wizard here. Anyway, thanks again. So today we're going to be reviewing through some case studies, and I'm bringing two case studies to illustrate some of the really important points about some of the financial considerations for transplant patients. We're going to talk about topic of end-stage renal disease Medicare, and we're also going to talk about how to tackle some of the expenses and costs associated with insurance near the end of the presentation, and then the challenging topic of medication costs. Medication costs can sometimes be an issue, so I'm going to provide some resources on how to help with that and give you some resources that are practical and things that you can access. So let's jump right in to the first case study here. The first case study is Maria, and I want to see if I can make this bar go away. There we go. Thank you. Maria is a 42-year-old business administrator with stage 4 chronic kidney disease due to long-standing hypertension and early diabetic changes. Maria has health insurance through her employer. Her kidney function is now 16, and she tells her doctor that she still feels pretty good, and dialysis has not yet been initiated. Maria has also completed her transplant evaluation at her local hospital where there's a transplant program, and she was successfully listed for kidney transplant before starting dialysis treatment. So Maria has not started dialysis. Maria's sister came forward as a living donor, and she was approved as a match, and she's now scheduled to receive a preemptive living donor kidney transplant. So preemptive is a word that transplant programs and sometimes doctors will use to describe a transplant process that happens before dialysis. So that's what that word means. It's an important. So here's the question to you to think about for just a moment. Does Maria qualify for Medicare under the end-stage renal disease program yet? Give you like 2 seconds on that. Maria does not yet qualify as an individual with end-stage renal disease because 1, she's not yet started dialysis treatment, and 2, she's not yet had a kidney transplant, although she's got a scheduled transplant because her sister was found to be a donor. So let's jump forward now a few weeks. It's now October 21st. Maria had a transplant on October 15th. It was successful, and she's now home recovering well after being in the hospital for 4 or 5 days. She's managing all of these new medications, and her follow-up visits She's feeling a little bit overwhelmed, but really, really hopeful. She's feeling better. Her doctors are giving her good feedback. Her labs are coming back really well. Before her transplant, she was told that there's a lot of important considerations about her health insurance that she needs to think about after transplant. So Maria was told that she has time to make these decisions. It's a lot to consider for her. She's a little bit overwhelmed, as everyone is in this particular situation. So the first thing that I'm wondering about is, how much time does Maria have after her kidney transplant concerning this really confusing topic around ESRD Medicare? Well, the answer to that question is 12 months. Maria has 12 months to think about this. So I bring this up because after you undergo a transplant, there's a lot going on, right? You've got a lot of new medications that you're taking. You've got, a lot of medications, a lot of labs, a lot of medical appointments, and even maybe some minor medical procedures that you need to do on top of all the other things that you got to do. Maybe it's being a busy mom, or it's 1,000 other things, taking care of your family and taking care of yourself after such a big ordeal. So what are Maria's options? And I put the warning up here because those of you who've already seen part 1, you're going to see a couple things that we've already talked about, but I want to review them with you so they're fresh in your mind as we kind of go through Maria's case. Okay, so reminder, go back and watch episode 1 that we did a couple weeks ago about some of the financial considerations, and we're going to review some of those ideas now. So here's some of the review. Medicare comes in parts, all right? The topic of Medicare is confusing, and one of the reasons it's confusing is because it's got all these parts. Medicare Part A is hospitalization coverage, covers care when you're in the hospital. Medicare Part B covers outpatient medical care, things like your doctor's visits, labs that you have, medical treatments that you get like infusion therapy maybe, physical therapy, occupational therapy, speech therapy, even counseling therapy with a psychologist or a clinical social worker. Medicare B pays for that. Medicare Part D is in David. It covers medications. And specifically, I'd like to say that it covers medications that you take orally in your mouth, not medications that typically go through an infusion. Those medications are typically paid for by Medicare Part B. And then there's another part of Medicare that sometimes people hear about called Medicare Part C. That's called Medicare Advantage. And that's when another private insurance company that you can purchase a plan through has a insurance policy that manages the entire Medicare benefit for you under one policy. Some people like that and they find that simpler. Some people find it more difficult. So you've got to be careful when you look into these kinds of things. So let's move on back to Maria's case. So after kidney transplant, Maria has some options with end-stage renal disease Medicare. Remember, she's also got time. Time's important. All right. So option 1, she can defer enrollment in the ESRD Medicare program. She doesn't need to do anything right now. That's one option she has. Number 2, she can enroll in just part of the Medicare program. She can enroll in Medicare Part A only, or she can enroll in Medicare Part A and Part B. Sometimes people call that original Medicare. So what I'm going to do is I'm going to talk through sort of the pros and cons of all of these decisions so you can be thinking about yourself in the context of Maria's case. So deferring Medicare costs, or deferring Medicare altogether after a kidney transplant, what does this mean for Maria? Well, what are the risks of not enrolling in ESRD Medicare? So the first concept, again, this is review from our last talk, is this concept called the 30-month coordination benefit period. You're going to hear me talk a lot about that in this discussion. So Maria is at risk for not having adequate coverage under her health insurance if she does not enroll in the ESRD Medicare program after what's called the 30-month coordination of care period. That 30-month coordination of care period starts on the first day of the month that Maria was in the hospital for her transplant. So you're thinking probably to yourself, wait a minute, the first day of the month that Maria was hospitalized for her transplant is when her ESRD Medicare entitlement starts. And that's also when this 30-month coordination of care period starts. That was before her transplant. You're right. If that's what you're thinking, You're exactly correct. And this is actually a good thing in the context of Maria because it gives her, again, options. I like options. Options is freedom. Options gives you more autonomy to make a decision that's good for you. So remember in the example that Maria had her kidney transplant on October 15th, 2025, right? So her Medicare entitlement and her coordination benefit period starts on October 1st, 2025. I know it's confusing, but stay with me. All right. So I've projected out into the future. When does her 30-month coordination of care period end? It ends on March 2028. Actually, at the end of March 2028. So that's a ways down the road, 30 months down the road. So deferral of enrollment in the ESRD Medicare Part A benefit means that Maria, this is a risk, that Maria will not get some of the financial protections down the road. So later, when she enrolls in Medicare Part B, if she decides to forego enrolling in the Medicare Part A benefit, then the Medicare Part B benefit later won't provide her some additional financial support to buy those really, really important medications that we call immunosuppression medicines that Maria is going to have to take for the rest of her life. Okay, so that's a risk. If she doesn't do this, that's a risk. All right. Access to lifelong protection to access to immunosuppression coverage under Medicare BID. So Medicare Part BID is this special program that came about a couple years ago under a new law that was passed that provides a safety net program for individuals who lose all access to insurance for whatever reason. All right. So if you're a person maybe 8-10 years down the road, and for whatever reason, you've lost access to all medication coverage. You don't have access through Medicare. You don't have access through a job. Maybe you don't qualify for protection under the Medicaid system in your state. Then if Medicare Part A was active at the time of your transplant, and so for Maria, that would be October 1st, 2025, even though her transplant happened on the 15th, the Medicare Part B ID program would be a program that she could enroll in that would provide her lifelong ability to purchase her immunosuppression medications, lifelong, right? So some of you might remember from our first talk that your ESRD Medicare entitlement after transplant lasts 36 months. Well, under the Medicare BID program, it doesn't matter how long it's been. If you lose insurance, the Medicare Part B ID program will allow you to purchase your immunosuppression coverage, and it's a very simple process to do that. And having Medicare Part A at the time of your transplant gives you the ability to use that program for the rest of your life as a safety net. It's a neat thing. It's something you should know about. Okay, that's a risk. If you don't do it, you won't have access to that program. So there's one of the big risks. Okay. Benefits of delaying enrollment in the ESRD Medicare. Well, why in the world would Maria consider not doing this? I've just given you some risks, right? Well, let's look at it. So benefits of not enrolling in it is because it might save her some money, right? Medicare Part B, you know, that second part of Medicare that pays for all the outpatient medical treatment I talked about, for most people, but not all people, it costs money. There's a Medicare Part B premium. And that premium gets more expensive depending on your household income. So the minimum premium in 2025 is $185 a month. Now, I mentioned that some people don't have to pay that, and I'm going to talk a little bit about that later in our talk about how that is and maybe how you might benefit from that later in the example of Maria. All right, Maria has some other options. She can enroll only in Medicare Part A. We talked about that in the last slide. And if Maria enrolls in Medicare Part A only, there's no premium for this. Under the ESRD Medicare benefit, people who qualify for Medicare, which is not based on your work history, it's based on the fact that you have end-stage renal disease, and that's an important distinction. Because good old-fashioned Medicare that you get because of your age when you turn 65, or because you've been on the SSDI, the Social Security Disability Insurance Program, for 24 months, that type of Medicare you get because you have worked and your employment has given you the capacity to have the Medicare program. Under ESRD Medicare, this is not true. you get ESRD Medicare because you have end-stage renal disease. This is often why children under the age of 18 qualify for ESRD Medicare, even if they've never worked a day in their life, right? Because it's not about work, it's about the meeting the criteria for ESRD, end-stage renal disease. So it's a nice thing to keep in mind. All right, so keep in mind that Maria was not on dialysis before her transplant. That means that her ESRD Medicare entitlement started on October 1st, 2025, even though her transplant was on the 15th. Again, your entitlement to Medicare is on the first day of the month that you're hospitalized for transplant, even if it happens later in the month. We also figured out in our example that the ESRD Medicare coordination of benefit period ends for Maria in March 2028. That means that Maria needs to have the ESRD Medicare benefit, both A and B, active and in place by the end of March 2028. So that's one of the reasons why Maria doesn't need to enroll in Medicare right after her transplant, because she doesn't necessarily need it until that 30-month coordination of care period is over if she decides to defer it. So that's something to keep in mind. So why would Maria enroll in Medicare Part A? Well, you probably already know some of this information. We've already talked about it, but let's talk about it again to be redundant and make sure we really help you kind of grasp this idea. Enrolling in Medicare Part A by itself at the start of Maria's ESRD Medicare entitlement on October 1st, what this does is it provides her financial protections later in life for immunosuppression medication costs. The really important ones, the ones you take for the rest of your life after you undergo a kidney transplant. This happens because when Medicare Part A is active, even retroactively back to October 1st in her case, that means when she does eventually enroll in Medicare Part B, which she doesn't have to do right away, that her Medicare Part B is going to do something it would have never done before. It's going to pay for the immunosuppression medications and make those medications cheaper. And that's actually going to happen not just once, it's going to happen twice for Maria if she decides to enroll in Medicare Part A when she's initially entitled to do that. It's going to happen when she enrolled in Medicare Part B the first time before the end of the 30-month coordination of care period. And this is the real win, and one of the reasons why I talk to my patients about this so much, is that when she turns 65 one day and she gets Medicare because of age, and she enrolls in Medicare Part B at that time, if she decides to stop working and needs that Medicare B benefit at that time, the Medicare Part B benefit, because she enrolled in Medicare Part A all the way back in October of 2025, is going to cover her immunosuppression for life, from 65 beyond. And that's a tremendous gift, especially when you think about retirement. And people generally have less money when they retire. Any way we can help our patients keep more money in their pocket, save money, and also have this sort of psychological confidence that they're not going to have a problem getting these medications that they need when they're retired, when they have less resources, it's a good thing. And this is one of the reasons why we talk about enrolling in Medicare Part A initially after you have a transplant, if you're a person like Maria who wasn't on dialysis prior to the transplant. Okay, that's a really important concept. I hope that makes sense. Okay, what are the risks of enrolling if only enrolling in Part A? I've talked a lot about why it's really helpful, right? But what are the risks if you do it just Medicare Part A only? Well, let's talk about that. So for people like Maria who underwent transplant before starting dialysis, enrolling in Medicare Part A, it makes a lot of sense, honestly. And I've already made the case for that, I think. But two things that Maria needs to keep in mind. One, enrolling in Medicare Part A only means that when you eventually do enroll in Medicare Part B later, it means that it's going to be a little bit more expensive. All right. So let me explain why that is. This is a little unusual, especially if you have a loved one in your life who's got Medicare benefits because of age or disability. They're not going to experience this most likely because the rules are different. Of course, ESRD Medicare has to be a little bit different to make it more confusing. So under ESRD Medicare, for every 12 months that a person has ESRD Medicare Part A, they will pay an increased level of premium of 10% for Medicare Part B during their initial ESRD Medicare entitlement, which ends 36 months later after transplant, so they'll pay 10% extra on that Medicare Part B premium. So in 2025, I've already told you that if you enroll in Medicare Part B, the premium is going to be $185 a month minimum, right? So if you defer your Medicare Part B a couple years and you enroll in Medicare Part A after your kidney transplant, then you might pay 20% higher premium for that Medicare B benefit for those few months that you have to maintain that ESRD Medicare benefit in Maria's situation. And I say few months because that 30-month coordination of care period is when she needs to have that Medicare A and B benefit both active. But that is all going to stop 36 months after transplant, because 36 months after her kidney transplant, Maria is not going to be entitled to ESRD Medicare benefits any longer, because officially she no longer meets ESRD criteria because she's 36 months after transplant. That's how the policy defines end-stage renal disease. It's kind of a complicated idea, and it's a little bit strange that Maria would have to enroll in the Medicare B benefit at all, right? But 36 months after that transplant, she'll no longer meet the ESRD Medicare eligibility criteria any longer. And that's a good thing. We want that, right? We want that. That's why we help people get transplants, okay? So let's keep moving forward. So those are two things that Maria needs to keep in mind about enrolling in Medicare Part A only, all right? There is one other risk that we need to talk about, and this is, again, confusing. When Maria enrolls in Medicare Part A only, and she decides that she doesn't want to enroll in Part B because she wants to save a little extra money, not have to pay that Medicare Part B premium, which again can be a wise decision for people, even if she's going to pay that extra 10% premium for every 12 months she hasn't had it. There's another thing that Maria needs to keep in mind, and this is incredibly important. If you enroll in Medicare Part A under ESRD and not Part B, then you can only enroll in the Medicare Part B benefit during what's called the Medicare General Open Enrollment Period, or General Enrollment Period. Well, when is that? It's between January 1st and March 31st of every year. So if a person has enrolled in Medicare Part A and they need to enroll in Medicare Part B before the end of their 30-month coordination of care period ends, they have to do it between the months of January 1st and March 31st of every year. If they miss that window, they are at risk of not being able to enroll in the ESRD Medicare Part B program, which could be very, very, it could be a big concern. And if they don't do that and they don't have the Medicare Part B benefit after that 30-month coordination of care period, what happens then? The Medicare benefit becomes the primary insurance. The Maria's group health insurance benefit becomes the secondary insurance. And if that Medicare B benefit is not active, then there's a big portion of her outpatient medical treatment that's not going to be covered, right? And if her employer benefit that she gets through her work is the secondary insurance coverage, it's very likely that they won't pay for medical treatment that Maria undergoes if the Medicare benefit is supposed to be the primary insurance. So this is one of the reasons why this is so important, that when you're in that general enrollment period, you make sure you mark on your calendar.
Craig, can I ask
Yes,
a question?
Karin. Yeah, please do that.
Because to me, it seems almost, I don't want to use the word criminal, but it seems almost not right by the commercial insurer to not pay for the person that the company is paying a premium for and forcing the individual to enroll in Medicare. I mean, is that a clear yes or no, or does that depend on the case?
So, yeah, I think that's a good question. And I'm going to answer it in a way that's not going to be completely satisfying. So if you ask me the question, have I ever met a person who is beyond their 30-month coordination of care period and has their group health insurance through their employer continue to pay for all of their care and has their been a situation where that hasn't been a problem at all? The answer to that question is yes, that has happened. Absolutely, it's happened. Why has it happened? I don't know. Maybe some insurance policies, under the fine print of how those policies work and the policies that the employer contracts with for their employees, it's got a carve out or something that allows for that to happen. But unfortunately, I have seen the other situation much more commonly. And when the employer-based coverage becomes the secondary insurance after that 30-month coordination of care period, they are not compelled under my understanding, and I'm not an attorney, so I skipped attorney school, but they're not compelled to pay for those insurance premiums if the Medicare Part A and B benefit are primary insurances. And this is a law that has been, this policy, this process has been around dating back to 1981. That's when the coordination of care period was initially introduced. It didn't actually come with the ESRD Medicare program when it was started back in 1972. It was something that was initiated later in effort to, I think, preserve the Medicare Trust Fund by requiring the employer-based group health insurance providers, the insurance companies, to pay for the first year of coverage initially, and then it transitioned to 18 months. I think that was in like 1992. And then in 1997, it transitioned to the 30-month coordination of care period. So this is a process, a policy that has been in place now for many, many years. And I agree with you. This is a major frustration. I think one of the most confusing aspects of the ESRD Medicare program. And I think this is really one of the big reasons why we're talking about it. Because when I've seen patients that have missed that window and have not enrolled, I've seen people at significant financial risk and having significant difficulty accessing the care they need after transplant, which is very scary. And that's why I take this so seriously and want to make sure I'm advocating for my patients and we're educating them, and why it's really important while we're talking about this today. And you're creating a space here with TransplantLyfe to do that. So that's my unsatisfactory answer to that, Karin.
It's really important.
Yeah,
thank you.
For sure. So, all right. So if Maria in this example enrolls in Medicare Part A only, and her entitlement starts on October 1st, 2025, when does she need to have both parts of Medicare? The answer is March 2028, by the end of March 2028. Why? It's because of that 30-month coordination of care period that we just got done talking about. So I hope this helps make this crazy concept a little bit easier to understand. It took me a long time to understand it. So if you're having trouble with it, don't feel bad. I work in transplant, and most people I know that work in transplant, some of the smartest people in the world that I work with here at Beth Israel, it's a tough concept for us all to wrap our head around. So there's nothing wrong with you if this is a hard concept. And it's certainly one that's frustrating. So, okay. What is Maria's final option with the ESRD Medicare benefit? She can enroll in both Medicare Part A and B if she wants to, right? So we've learned that she can forego it, right? And then enroll in those programs before the end of the 30-month coordination of care period. We've learned that she can enroll in Medicare Part A only, but then eventually have to enroll in Medicare Part B during that general open enrollment period I just got done talking about. And then Maria might decide to enroll in both parts of Medicare, way back when she was initially eligible for that after her kidney transplant. So if she does that, Medicare Part B will help support the cost of her immunosuppression medications right away. It'll help as a secondary insurance because her group health insurance is the primary, right? She won't need to worry about enrolling in Medicare Part B later because of that silly 30-month coordination of care period thing we've been talking about, because she's already got the coverage. Her primary insurance and her Medicare insurance, which is initially secondary, after that 30-month period, after March 2028, it's going to become her primary. Medicare will just swap out and make that happen. Now, I have met a patient or two over the years where that hasn't necessarily been clear to the insurance company, and it hasn't been necessarily clear to the hospital. And a patient might get a kind of a bill might show up at their house, and they may be like, well, I've got all this insurance. Why am I getting this crazy bill? And sometimes the private health insurance needs a little bit of a nudge and to remind them when this kind of thing happens, who's paying first and who's paying second. And there's an agency that I would like you to know about. I don't have a slide for it, but it's called the Medicare Benefits and Coordination Department, and you can Google that, Medicare Benefits and Coordination and Recovery. It's what it's actually called, Medicare Benefits Coordination and Recovery. And they have an amazing team of people. It's like the only part of Medicare you call and you never have to wait on hold. They're so good, and they will help you as a person figure out where are you at in this 30-month coordination of care period. These people who work for Medicare will tell you that information. And it can be really, really helpful. And they can straighten this out if it's ever an issue. Okay, so, all right, so costs. This is super important. When we talk about Maria's option to enroll in both Medicare Part A and Part B, well, there are costs associated with that. So I've done some math. I'm not a math guy, but I've done some math here. And I want to make this very clear about what this would cost her, something you would need to think about. So if Maria enrolls in the A and B program right from the start, right? In 2025, she's going to pay $185 a month at minimum for the Medicare B benefit. So if she pays for that Medicare B premium over 36 months, that's going to cost her $6,660 over the course of that 36 months. Well, that's a lot of money, right? But if Maria decides, based on the 2025 numbers, if she decides to defer Medicare Part B, only enroll in Medicare Part A, even though she knows she's going to probably pay a 20% higher premium for those few months that she needs to have it, she's going to spend about $1,554. So this is really important. I talk to my patients about this all the time, because I get asked, should I just enroll in Medicare A and B right now and just get this all over with so I don't need to worry about all this craziness? And I say, yeah, no, you should definitely not you should think about it. And I say you should think about it because there's a big difference between $6,660 and $1,554. And this is just in Maria's situation. It's going to be a little bit different for the rest of you because your 30-month coordination of care period is going to fall at a different time of the year based on the date you got your transplant, if you have a preemptive transplant like Maria had. But I wanted to provide this example to make this crystal clear. It makes financial sense sometimes to defer enrolling in Medicare Part B. And in this example, this is one of the reasons why Maria may not decide to enroll in both programs. Does that make sense? Karin, does that make sense to you?
Yes. Yes.
Perfect.
Thank
All right.
you.
Excellent. All right. So what if Maria decides to not enroll in ESRD Medicare after all this transplant? What if Maria is one of these people that says, I'm just going to roll the dice. I'm just going to see if my private group health insurance benefit that's taking care of me for the last 30 months is it's just going to keep paying the bills, right? And in that situation, if Maria was my patient, I would have to have this conversation with her. One of the things that your doctors and your social workers and anybody who's on your transplant team should always be doing with you is talking about the risks and the benefits of your decisions, right? That's about your medications that you take. That's about the surgical procedure you undergo. You should understand the risks and the benefits. So what are the risks and benefits? If Maria comes to me as her social worker and says, Craig, I'm just not going to do it. I'm like, okay, well, you're an autonomy. You have your own autonomy. You can make your own good or bad decisions. But let's talk about what that might mean for you. So Maria would be at risk of not having adequate health insurance coverage following the conclusion of her coordination benefit period, that 30-month thing I keep bringing up over and over again. That would mean that her primary group health insurance wouldn't be there, ESRD Medicare. Her group health insurance through her employer would be her secondary insurance, and they may not pay the bills, right? That means that Maria might be at risk to pay for all the care that she receives, not only in the hospital, but also her outpatient care, her labs, and potentially her immunosuppression. Okay, so this would put Maria at significant financial hardship and risk, and I would have to have that conversation with her. And so if you're a person who's thinking about this, pay attention to this slide, that these are the risks. These are the benefits are you don't pay the premium, right? That's a small benefit in my opinion, when it comes to the significant amount of risk that you might be taking if you defer doing this. Okay, so again, understanding how ESRD Medicare works, it's an essential part of your transplant plan of care, and that's why we're spending so much time talking about it. Okay, so that's case study number 1. So before I go on, I want to ask Karin and anyone else if there is a question after going through all of that information.
And also Kevin, I guess, Kevin, do you have any questions?
At this time, Craig, perhaps you could just quickly answer one thing that was raised in the chat regarding the coverage for ESRD Medicare, clarifying whether that is 30 or 36 months.
Okay, that's a great question. You know, and I'm with you, the person who asked this question, right? Like, why do the people who make these laws have to make them so complicated by giving us all these crazy numbers? 30 months, 36 months, like that's nuts, right? So thank you for the question. I think it's a good one. So the 30-month coordination of care period is 30 months, 30, okay? The ESRD Medicare entitlement after transplant lasts 36 months, right? So thank you for the question. So it gives me an opportunity to kind of talk about that. After that 36-month period is up, after a successful kidney transplant, if a person hasn't had to go back on dialysis treatment or hasn't had to undergo another kidney transplant, that ESRD Medicare entitlement ends, and the ESRD Medicare benefit should also end, meaning you're no longer having to pay for that premium. Yay, that's a good thing. So thanks for the question. I hope that answers it. Kevin, any other questions?
Let me have a quick look here.
Did we talk about there's a longer one here as well, Kevin.
Let's see. Quickly, Craig, another question regarding ESRD Medicare. Is there a waiting period after filing for ESRD Medicare?
A waiting period. So the official answer on that is going to be no. And the reason why is because, you know, in Maria's example, you know, she underwent that preemptive kidney transplant because of her living donor transplant on October 15th, right? So she enrolls, even if she enrolls in November or December of 2025 in this example, right? She could backdate her ESRD Medicare benefit all the way back to October 1st. Okay, she's got 12 months to do that. 12 months. So there's not a waiting period. Now, I know why the person asking the question is probably asking it, and it's because they're really, really smart and they understand the difference between the ESRD Medicare benefit and the Medicare benefit that people receive because of disability under the Social Security Disability Insurance Program. So the person's asking the question because they know that when you qualify for Social Security Disability Insurance benefits, so not ESRD Medicare, okay, that you become eligible for you become eligible for Medicare benefits under SSDI after you've been disabled for 24 months. Now, it's not exactly 24 months, it's actually 29 months. I know if you look at the policy, it says 24 months, but they don't count that 5-month waiting period that's there until you become benefit eligible. So it's on that 5th month that you become eligible to receive SSDI, and then it's 24 months after that date, that's where I came up with 29 months, that you become eligible for Medicare under Social Security Disability Insurance. So let me throw a curveball. If you have SSDI and you've been on disability for 2 years and you now have Medicare because of your SSDI benefit, and then you develop ESRD Medicare benefits, the ESRD Medicare benefit rules apply, right? This is also true if you're over the age of 65 and you have ESRD Medicare, that 30-month coordination of care benefit thing, that applies for people who are over the age of 65, even though they have Medicare benefits because of age. Those ESRD Medicare rules will still apply. So if a person is, say, 64 years of age, they enroll in ESRD Medicare because they started dialysis treatment or had a transplant, and then they turn 65, you know, just a few months later, the 30-month coordination of care rules still apply to them. So if they have a group health insurance benefit through an employer, or through their own job or through their spouse or whatever, their employer-based group health insurance benefit will continue to be primary, even if they work for a small employer under 100 employees for 30 months, which is super different than how the coordination of benefit period works for people with Medicare benefits because of age or because of disability. So that's a good question. It's a complicated answer, but there are distinctions between how ESRD Medicare works, and Medicare works because of SSDI and because of age. I hope that's helpful.
Excellent.
Thank you, Craig.
So,
We went through the
okay.
questions in queue, so I think we're ready for case study number 2.
All right. Could we make it more complicated, right? That all these different rules. That's going to be the theme of the day, right? So case study number 2 is James. James is a 58-year-old gentleman. He's receiving in-center hemodialysis 3 times a week. He has commercial health insurance. He's not yet covered by Medicare. He's completed his evaluation, and he's currently active on the national waiting list for a deceased donor kidney transplant. He hasn't been able to find a living donor, and James continues dialysis while he's awaiting his future transplant offer. This is about, here at Beth Israel, this is about 70% of our patients that we meet. And so let's look at these things. So remember the 30-month coordination of care period, you're gonna have like nightmares about me saying that over and over again. I apologize. Concerning ESRD Medicare benefit, we need to first ask the question in the context of James, like, how long has James been on in-center hemodialysis, right? We need to know the answer to that question so we can think about when should James enroll in the ESRD Medicare program. So if James just started hemodialysis in the last few months, I'm asking you, viewers, does he need to initially enroll in ESRD Medicare right away if he has his group health insurance? What do you think? You hear like the Jeopardy music in your head. The answer is, if James has only been on hemodialysis for a few months, then he doesn't need to enroll in ESRD Medicare, but he can if he wants to, but he doesn't have to. Why? It's because of the 30-month coordination of care period. He's got group health insurance benefits provided through his job or through his spouse's work, and the rules don't compel him to necessarily enroll in ESRD Medicare right away. So I have a lot of patients who come and talk to me sometimes, and they say to me, hey, my dialysis team has told me that I need to enroll in ESRD Medicare, and they've only been on ESRD, or they've only been on hemodialysis for a few months, or they've been on peritoneal dialysis for a few months, or home hemodialysis a few months. And my question back to them is, why? Why are you being asked to enroll in the ESRD Medicare benefit now? Does it make sense for you? And often patients don't know the answer to that question. Of course, that's why they're asking me. And what I tell them is, I want you to really understand, why the dialysis team is asking you to consider enrolling in the ESRD Medicare benefit. How does that impact you financially? Does it make sense for you? And that's why we're talking about James's case here. So James should really consider enrolling in Medicare when he's closer to the conclusion of the 30-month coordination of benefits period, right? When does James' coordination of benefit period start? That's a complicated question. Of course, it's complicated. So when a person starts hemodialysis, their coordination of benefit period, and I probably should duck right now because someone's going to throw something at me. But when you start hemodialysis, your coordination of benefit period starts the first day of the 4th month after you started hemodialysis. I'm ducking now. The first day of the 4th month after you start hemodialysis. All right. That means that your 30-month coordination of care period in James's situation, it starts then. It starts on the first day of the 4th month after he starts hemodialysis treatment. If he's on peritoneal dialysis, he starts basically when he starts peritoneal dialysis treatment. But the actual language around that is when he initiates his peritoneal dialysis or home dialysis training program. That's when an individual becomes initially entitled to the ESRD benefit. and that's when their 30-month coordination of benefit period starts. So when you're thinking about this, you got to think, which form of dialysis treatment am I on? Am I on home dialysis, or am I on in-center dialysis? That's the answer to that question is going to have a lot to do with when your 30-month coordination of benefit period ends. Okay, so again, a confusing topic, a confusing thing, but it's something you need to think about. All right. So if James does not enroll in the ESRD Medicare benefit at the conclusion of his coordination of benefit period, he, like Maria in our last example, would be at risk for not having adequate health insurance coverage, right? So if he goes 30 months, doesn't enroll, that means that his group health insurance benefit becomes a secondary coverage. Medicare should be his primary, even if he doesn't have it. And that means that he's at risk for not getting coverage. When does his ESRD Medicare entitlement end? It ends 36 months after the transplant that he's waiting for. So 36 months, again, 30 and 36, all right?
So Craig,
well, what if James, yes, Karin.
Sorry, so if it starts on the first day of the 4th month, the first 3 months, how is James paying for his dialysis?
So in James's case, in this example, he has group health insurance. So the group health insurance benefit is paying for his dialysis, and it's going to continue to do that just fine for the first 30 months of his dialysis treatment, right? It's after that 30 months when the Medicare benefit has to be there because it'll serve as primary. If an individual doesn't have group health insurance benefits, they may have coverage through a plan through their state marketplace under the Affordable Care Act, or they may have primary coverage through their Medicaid benefit in their local state. And remember that the Medicaid benefit, it's available in every state. It's called something different in most states. Most states don't call it the Medicaid program, they call it something else. Here in Massachusetts, we call it Mass Health. Other places call it other things. So, so generally speaking, the coverage would be provided through that group health insurance benefit or one of these other benefits. Also COBRA, James, what if James no longer is working? His employer has offered him the COBRA benefit. He's accepted that COBRA benefit, although it's probably quite expensive. That COBRA benefit would certainly provide him the necessary insurance coverage that he would require for dialysis treatment. So how does James enroll in the ESRD Medicare benefit? How does he do it? How? Well, let's look at it. So can I enroll in ESRD Medicare online? Who do I talk about enrolling in ESRD Medicare? Is there a specific form for doing this? Well, a hint, yes. All right. So can he do it online? No. Sadly, no, right? So people who have the Medicare benefit because of age and disability, you can absolutely enroll online. Yay, it's super easy to do that. But for ESRD Medicare, you can't. There's no online application for that. At least one that I'm not aware of. So no. At the time of this, no. Who can James talk to about the ESRD Medicare? But besides the amazing people at his dialysis center or his transplant center, he can talk to the local Social Security Administration office. There's also a national hotline, but I will tell you, you'll probably get a little further by talking to your local Social Security Administration office. All right. Is there a specific form that he could use? Yes, there is. It's called the CMS 43 form, and it stands for the Application for Hospital Insurance Benefits for Individuals with End-Stage Renal Disease. So if my slide deck here is able to be shared, that's a link that you can use to find this. You can also very much easily Google the CMS 43 form, and you will find it on the CMS website. You can download it. It's actually a very easy form to fill out. You don't need, a social worker to do that, although I help people do it all the time. It's very simple to fill out. It asks just a lot of very basic information, and generally it's pretty simple. But if you have a question about it, bring it to your social worker or your financial coordinator or someone that you trust, and they'll help you with this, okay? So after James submits his application for the ESRD Medicare program, it really doesn't take that long for the ESRD Medicare benefit to be activated. There is one thing, though, that needs to be done to make this really happen, and it's this special form called a CMS 2728 form. Again, I should probably duck because of all these crazy terms I'm throwing out, like CMS 43 and CMS 2728, but the CMS 2728 form is a form that you will sign after you initiate dialysis treatment. But if you're like Maria and you undergo a preemptive kidney transplant before you start dialysis, you'll fill out the CMS 2728 at your transplant center. And then we would submit that to your local Social Security office. And that document is needed. And it tells the Social Security Administration that you're a person who officially meets the medical criteria for the end-stage renal disease designation. And it's what provides you the entitlement to that. It's also a helpful form because it tells Social Security when you're no longer entitled to the ESRD Medicare benefit later, 36 months after transplant. So it's important that this documentation is submitted. Okay. All right. So that was case study number 2. Kevin, do we have any questions, or Karin, any questions about that second case study?
Craig, were you caught up in the chat? Karin, any questions from your end?
No, I'm good. Thank you.
All right. So
Very clear.
let's talk about some practical stuff that you might find helpful. All right. So if I enroll in the ESRD Medicare benefit, will I have to pay for additional insurance premiums? Boy, that could get expensive. What do I do? Well, the answer is you probably will have to pay for additional premiums because, again, Medicare Part B, that part that pays for all the outpatient medical care, it does cost money. Again, I said a minimum of $185 a month, depending on your household income. But some people, because of some other benefits we're going to talk about in a minute, do get some coverage for that, and it doesn't cost them money. But you have to continue to pay for that. And if you have group health insurance benefits, you'll have to also continue to have money probably deducted from your spouse's paycheck or your paycheck to keep that coverage going. And that can be really, really challenging. So this is why I want to talk about something I talked about in episode 1 called the American Kidney Fund Health Insurance Premium Program, or sometimes we call it HIP, H-I-P-P. That website that's at the bottom of this slide is where you can learn more about this. Your dialysis team, if you're on dialysis, should be able to tell you this. They probably have a financial coordinator who's an expert, a total pro at helping apply for this benefit. This benefit is a game changer. Now, it's not eligible. Not everyone is eligible for it. It is an income tested program. I believe from memory here that the eligibility criteria is about 400% of the federal poverty level. That's a pretty big number. So if you have a household of 4, that's a pretty big number, and hopefully a lot of people will be eligible for that. What does this program do? It can provide you reimbursement or actually pay your insurance premiums for both Medicare Part B as in boy. It could pay for your employer group health insurance premium as well. So this is a huge win. So if you're a person who's on dialysis treatment, you need to ask about this. And honestly, even if you think that you're over income, you should apply. Just do it. Make them tell you you're not eligible. That's my advice. Apply, apply, apply. If you get it, it's a huge win for you. And, if you are working, but you're on like a short-term disability leave, you've probably taken a hit in your income, and maybe you'll qualify even though you think you don't. So do it, apply. Any questions about that? Okay, I'm going to go on to the next thing. So I mentioned this group of people that sometimes doesn't have to pay for the Medicare Part B benefit. And these are people who qualify for what are called Medicare savings programs. So Medicare savings programs are programs that are across the entire country. They're available in every state, and they're part of the state Medicaid program. So you apply for these programs through the Medicaid office where you apply for the Medicaid program in your state. All right. These programs, and there are 3 of them, they provide financial support to help cover the entire cost of your Medicare Part B premium. That's a big deal, right? They could also provide additional coverage depending on the program that you're in to function as a secondary health insurance beyond your Medicare Part B coverage, meaning that if you didn't have employer-based group health insurance coverage, these programs would help cover the other costs that Medicare Part B doesn't cover. Because remember from our first talk a few months ago, back in June, we talked about how Medicare Part B is an 80-20 program. It covers 80% of the cost, and there's a 20% cost that's still the responsibility of the individual. So that's where your group health insurance as a secondary coverage is helpful, or a Medicare supplemental policy, or the Medicaid program in your state being a secondary insurance. These Medicare savings programs can help save you big dollars if you qualify for them. They are income tested and they are also asset tested. So not everyone's going to qualify. So what are the names of these crazy programs? They've all got weird names. The first one is called Qualified Medicare Beneficiary, QMB. The other one's called Specified Low Income Medicare Beneficiary, SLMB. The last one is called Qualifying Individual Program, QI. The QMB program, the one there at the top, that's the one that functions as a secondary insurance under your state Medicaid program. The SLMB, number 2 there, that program only pays for the Medicare Part B premium. It does not provide any additional health insurance coverage. And that's also true of the QI program. Although I'm not as familiar with the QI program, so if I got that detail wrong, forgive me in advance, but I think it just provides coverage for the Medicare B premium. Okay, so again, even if you don't think you qualify, apply. All they can say is no, there's no harm in doing it. Okay, good things to know about. All right,
Just
extra
a
help.
time check, Craig. We have about 3 minutes left.
Okay, well, this extra help program, I'll just show you the slide. This is a program that helps pay for the Medicare D as in David program, the drug prescription program. It's probably the most underutilized program with Social Security to help pay for drug costs. It'll make your drug costs cheaper, and it might make your Medicare D plan free or reduce the cost significantly. There's no harm in applying. You should do it. All they can say is no. If you get it, it's a big deal. So look at that program at that link I provided to you there. All right. What do you do if you can't afford medications? What if your doctor's prescribed you a brand name drug, maybe a drug that's recently come out that is very, very expensive? And let's say maybe you have Medicare Part D as a drug prescription plan, and your doctor has prescribed you a medication like atovaquone after transplant. We sometimes call it Mepron. This amazing organization called Needy Meds has been around for as long as I've been a social worker now. It is a warehouse of pharmaceutical assistance programs. Check out this website, put your brand name drug in, even if you're on the generic version of it, put the brand name drug in. This program will provide you likely a potential pharmaceutical assistance program that might be able to provide you that expensive medication free. This is an awesome thing. I've been using this program for years and I trust it. They provide excellent information. They also provide information about coupons to help reduce costs of medications. Some states, if you have Medicare, you can't use a coupon like that. In some states you can. So you need to just check the rules out in your state. All right. These are coupon programs that you probably have heard of in the past, things like GoodRx or Single Care or WellScript, that you can use to generate a coupon to buy a medication if it's more expensive. Sometimes it's helpful, sometimes it's not. If you use these programs, you cannot use your group health insurance benefits to pay for them or your Medicare Part D program. All right, this last thing I think is one of the most underutilized resources that are out there. RX Outreach Pharmacy is a great resource. It provides, it's a nonprofit pharmacy. You don't use your health insurance to buy medications through it. You can buy medications, many medications here at a very, very low cost. I think it's something that you should check out and learn about. It's a great program. It's been around for years, and it's an excellent resource and a way to save some money on medication. So check it out. Anyway, these are some of the resources that I thought of when putting this together to help save you some money on your medications, and I hope this has been helpful. Any last questions for me?
Thank you so much, Craig. And let's see if we have any questions. I think there were a lot of links placed in the chat here by Kevin. Kevin, any concluding remarks from you as a recipient and someone who's gone through this and maybe leverage some of these resources?
Craig, I just want to say thank you for organizing all of these resources into one spot, particularly when it comes to helping pay for the pharmaceuticals, particularly those immunosuppressants that can be rather expensive. To your point, it's always important to take a look at the cost of those meds, even if you think you're getting the best possible deal, as there are avenues of support out there. I tried to put as many links as I could in the chat, but we'll also have your slide decks available on our website for folks, or they can obviously go back and watch this recording as well. So thanks for putting this together, Craig. Really appreciate it.
Yeah. Man, this has been amazing. I am so proud to be a part of this and what Lyfebulb is doing and the information you're sharing. And I hope this is helpful. And this has been a great experience. Thanks so much. And I hope this information helps some people.
So Craig, I really think it does. I think it's incredibly helpful, not only to go through the cases, but also have these resources. And I think what we'd like to do is obviously to have the deck, this overall deck available.
Yeah.
And we can share that. I guess if that is possible, if you allow us, we can
Yeah.
send it out to those individuals who would like to go
Yes.
through it in more detail.
Yes.
And
Please.
obviously the webinar is recorded, both this one and the first, and they are available on TransplantLyfe.com, where we also hope that and we encourage recipients, donors, care partners alike, providers, to start a conversation about this, because it is probably one of the most complicated areas of transplantation. The drug regimen is given to you by your physician or your pharmacist, and you kind of follow it. You have side effects, you go back. But this is something that I think many patients feel they're a little bit alone, dealing with, because you call your doctor, you call your nurse, your drugs seem to be, they're obviously really important, but you can't take your drugs without being able to pay.
Right.
I really encourage individuals to reach out to their social worker at their centers, but also to go to our site and start a conversation and ask questions if you do not feel fully educated by these two. Which, by the way, I've heard this a few times and I still learn so much every time. So I think we're all in the same boat here. So thank you, Craig. Really appreciate you and Kevin, of course, who brought us Craig, and such an amazing community manager for all. We look forward to the Transplant Congress that is taking place over the next few days, and I'm sure that at our table and at our booth and in our poster presentations, there might be other individuals who ask about these questions, and we will refer them back. But thank you and have a wonderful evening.
Thank you so much.
Thank you, Greg.